Hello, my name's Joel Dunning and we're here at STS 2024 in San Antonio, and I have the greatest pleasure of being with one of my favourite thoracic surgeons in the whole world, Alan Sihoe from Hong Kong. The best uniportal surgeon, so innovative, great talker, and it's such a pleasure to have you here. So great to see you.
Thank you so much, and you have to know the feeling's mutual. I feel the same way about you.
And we've already been talking for ages, and we could probably make this about a 2-hour video, but today we're going to concentrate on segmentectomy, which is obviously something very close to your heart. It's an exciting time, isn't it, to be in the world of segmentectomy. So tell us a little bit about your journey in segmentectomy, I guess from 10 years ago to the situation we're in now.
Yeah, I think segmentectomy, for surgeons of our age, when we were in training, it's always been one of those, it's a bit tricky operation. We were kind of a little bit afraid to dip our toes in the water because of the previous evidence that suggests it's maybe not so good. But of course, that's all changed over the last few years, hasn't it? I mean, with the two big randomized trials, it's really changed the landscape, and now everybody is really getting into it, and we're just rediscovering our passion for this kind of surgery, especially through minimally invasive approaches. I think what we're really hoping to highlight here in this meeting in San Antonio is how far we've come and really how far forwards we need to go, because there's still many unanswered questions. And I'm really excited about this session we have here in STS 2024, because it's not only talking about this really hot topic, but we also have this joint session between STS and ASCVTS, the Asian Society of Cardiovascular and Thoracic Surgery. So we're bringing in experts from both sides of the Pacific, and as you know, a lot of the work being done in sublobar and segmentectomy nowadays really comes from our part of the world in East Asia. So it'd be great to have this sort of cross-Pacific sort of interaction, and hopefully, some of our audience will gain from that.
Yeah, and it's a really interesting point, that the contrast between the Asian populations and demographics and the Americans. Maybe just from your observations, how do you think those patient populations differ, and what have you seen in your experience with that?
Oh, that's such an important point, and it goes straight to the heart of sublobar surgery, because as you know, the emerging evidence, I think, in recent years is that we have a lot of non-smoking lung cancer patients in Asia, and it's emerging that it could be a completely different biology, of course, a biology that really suits segmentectomy or sublobar resection really to the max. And so I think that's one of the areas we need to explore. Another really important area that is emerging as we're doing more segmentectomies, of course, is multifocal lung cancer. I think as we're doing more and more screening, we're seeing more and more of these multifocal adenocarcinomas all around the world. They're perfect for segmentectomies. In fact, I think it's probably one of the major indications for this kind of surgery. So yeah, definitely a lot of prospects into it.
And certainly in the West, some barriers or concerns for segmentectomy are the issue of, what if I get an N1 disease? Or what if I take out the N1 nodes and then 2 weeks later I discovered it was positive, the stress about that. So what would you recommend to somebody who's a little bit worried about that? How would you approach that?
This is very controversial. I think anything I say I'm going to get attacked for. I do realize there are some good friends of ours that we know in Europe who are real advocates of doing the frozen section on table and converting to lobectomy if it's positive. There are also other voices that really, if you look at some of the clinical evidence that's out there, there isn't actually that much improved outcomes if you do convert to a lobectomy. At the end of the day, it's all about survival after cancer, and at least to my mind, I haven't really seen compelling evidence that say that if you do convert to lobectomy, you don't necessarily get better outcomes. But I don't know, I'm open to be persuaded. We'll see how the evidence goes.
Yeah, it's an active area to have a look at, and big databases probably will be that answer, won't it really? And then maybe just for the audience out there, some people that might be a bit lower in their segmentectomy experience, what do you think of those key little extra things that really help you to do a great segmentectomy?
Oh, that's such a great point. I think when we're looking at the landscape of segmentectomy surgery in recent years, a lot of it is focused on who we should be operating on, but the other big area of research is how we should be doing the segmentectomies, whether it's preoperative localization, intraoperative definition of the anatomical planes and the lesions. There's so much out there. At the moment, because there's so many options, I think the evidence for each one of them is still relatively limited. And then really at this point, I think it's really up to a lot of our younger surgeons who are really interested to go and explore, try all the different techniques. Personally, I'm in Asia. I've had a lot of experience with the preoperative 3D reconstructions, not necessarily the marking, but that's one avenue to explore. But yeah, if you're a young surgeon out there and looking to do segmentectomies, expose yourself to everything, not just one particular path. That's my advice.
Yeah, sometimes I kind of recommend trying going like a guess-free segmentectomy. Don't leave anything to chance, really. So if you can mark things, mark so you know where it is, because it's always nice to know exactly where it is, because you've got to have good resection margins, haven't you?
So
and then
true.
exactly as you say, 3D reconstruction, really spend an hour, half an hour looking at every single vessel, and then inflate the bronchus, occlude the artery, make sure you know where your arterial and bronchial resection margins are. Yeah. So and then make that guess-free. And
that's a great point, because at the end of the day, as we all know, I mean, curing the cancer is priority number one, and keeping patients safe. So, I mean, a lot of the time we jump onto the bandwagon of these new surgical types and we're thinking, oh, we got to get this done in this way. That's not necessarily true, is it? You just need to cure the disease while the patient is safe, and planning ahead, using these technologies to forward that's so key to it.
And obviously CalGB had a wedge group in, so wedge resections. So what's your view on wedge resections for primary lung cancer then?
Yeah, as we know, I think the argument that segmentectomy traditionally was better than wedge resection, yeah, you do have the survival data to show that, but what we haven't shown is why. And one of the hypotheses is that with a segmentectomy, you're simply getting wider margins. And therefore the argument goes that if you can do a wedge resection with equivalent margins as a segmentectomy, well, maybe you can get just as good results. And maybe CALGB is pointing in that direction. We don't know. There's more work to be done, obviously. The little danger, a little caveat about that is that a lot of people I've noticed are taking the CALGB data to just reassure themselves that, hey, I don't need to do a segmentectomy, I can just go ahead and do a wedge resection. And I'd be a little bit cautious about that until we understand why they get good results in CALGB with wedge resections. I don't think it's a license to just do wedge resections on anybody.
Yeah, and I think the other thing to say is it wasn't just a wedge resection, it was wedge resection and lymphadenectomy. So because in surgeons' minds we're used to wedging for diagnosis, but this is a very different wedge resection, isn't it? And that's where segmentectomy has the upper hand a little bit, because you do a better lymphadenectomy. So in my head it's about the margin and the lymph nodes. And at the end of the day, the 12 and 11 lymph nodes are the first place the cancer's going to spread, isn't it really? So I guess it's a different wedge resection, if you agree. Yeah.
So true, so true. Yeah, I mean, it goes back to what you were saying earlier about whether or not we should be converting to a lobectomy, whether we should be doing these frozen section things. I think one of the elements of that debate is whether conversion to lobectomy is the way forward, or whether adjuvant therapy is the way forward in this situation. I don't think we'll get into that, but it's very controversial, isn't it?
And then last year, Giuseppe Cardio and René Pedersen released some GGO guidelines, and I think there are a sensible sort of way forwards and things. But how do you see the differences in treatment of GGOs in Asia and in the West? Because I guess it's quite a liberal the surgery in Asia. And if you created your own guidelines, do you think they'd be a little different?
Yeah, I mean that's a great point. I mean, these European guidelines are really a game changer, and points the way forward. I think this is how we need to protocolize our management. Certainly within ASCVTS in Asia, we're already talking about formulating our own guidelines in Asia. And as I said, we may be facing a different kind of biology, cancer biology in Asia. So my own personal take on it is that rather than converging on a universal set of guidelines around the world, it might actually, I think, might go the other way. We might need regional guidelines, or based on different genetics and biology across the world. That's true for sublobar resection. It's probably true for how we deal with screening detected nodules in general.
Yeah, and just finally to finish off, technology is going crazy out there in thoracic surgery. I mean, it's a great time to be a thoracic surgeon, isn't it? And what's your 10-minute take on all these robotic bronchoscopes, actual robots, technology? Where are we going to be in 5 years' time? What do you think your average cases are going to be?
Well, my own personal take, really from previous experience, is keep an open mind, isn't it? Yeah, you're going to expect out of every 10 of these new technologies, maybe half of them are going to work, half of them are going to fail. You never know which one is going to work or not. But the idea is keep an open mind. I think really our experience over the last 20, 30 years in thoracic surgery is that every time new technology comes out, there's always going to be a bunch of naysayers and criticizers who say, no, this should be done. But we need to keep an open mind. At the same time, be wary of jumping onto the bandwagon prematurely. I think we need really intrepid pioneers like yourself who are going to try and do good research on these technologies before we actually find out. As I say, I think one of the tendencies, especially amongst a lot of our younger surgeons, is that, wow, that looks really exciting. I want to get on that straight away. But yes, get on straight away to experiment with it, but don't necessarily accept it straight out from the manufacturer that this is the holy grail. Be careful with that. I think we do need to develop the evidence in a methodical and logical approach.
Yeah, and I guess the sort of biopsy and ablate sort of pathway, 5-10 years time, that's something we need to go into carefully and not to get too beguiled by industry, really, isn't it? Because actually that's a whole different way of treating early stage cancers, isn't it?
Yeah, I think if I was a patient and this was a mature technology, I confess I would like that too. I mean, no cuts, sounds great. But we do have to bear in mind that, even with the largest series so far in the world, whether it's from Asia or from London, the long-term follow-up is still relatively weak. So until we actually get some good outcome measures, good long-term follow-up results, it's a little bit premature, I think, to put on a pedestal. It's certainly worth investigating, definitely. But let's stay in touch and see where this heads.
Yeah, well, I think that's a good place to end. Let's stay in touch. I think we could talk for about 3 hours, couldn't we, really? But yes, so great to see you again, and thank you so much for coming to talk to us here at CTSNet. It's a real pleasure. Thanks a lot, Alan.
Thanks so much.
Great.